All right, let's first look at these cases, okay? So our first case, you guys have this one, right? Case A. Good. All right, so we have a 38-year-old male. He's 5'10", weighs 154 pounds. Blood pressure is 125/78. His chief complaint is aesthetics, okay? He doesn't like the spaces in his upper teeth. Obviously, that's important to him because he's a bartender and he's in front of his clients every day, all right? His medical history includes diabetes, hang gliding accident, which resulted in surgery. He smokes 1 pack of cigarettes a day and uses chewing tobacco. He's taking insulin, all right? And his dental history includes random visits to the dental office for emergency extractions. So he waits until he's in pain before he gets treatment done. Okay? So you guys see how we did that, right? This is basically what you want to do. This page is probably the most boring page when you do your boards, but this is where a lot of your information is going to come from, okay? And the reason why I say that is a lot of times, even though they say some things here, like sporadic visits for emergency extractions, sometimes they'll include an x-ray of a patient that has all their teeth, okay? And so what's important is that you understand sporadic means occasional, just like whenever he needs it, he shows up. Okay. Anyway, you want to look at this history because sometimes the history is not going to match what your clinical findings that they give you are. Okay, because you're going to want to marry the two. In this case, it does match. Okay, he's had multiple extractions. He's lost all of the teeth in quadrant 3, in the posterior of quadrant 3. I'm sorry, 2. He's lost most of his molars, except for he has 2 molars remaining in the first quadrant. We've charted some cavities. Okay, this is called a clinical carious lesion. All right, clinical carious lesions are charted. Radiographic ones may or may not be charted. Okay, that's important for you guys to make a distinction between. Okay, you guys see you guys see my screen. I don't know if you can see my mouse. Okay. So if you see my mouse, you see this tooth number 4, there's this little black dot that's here on the tooth. That black dot means that when you looked in the mouth, you saw a cavity. All right. They are going to chart on here what you can see clinically. If you look down at the key here, it says clinically visible carious lesion. Sometimes we have carious lesions that are not clinical, but they are radiographic, right? Sometimes we can't see them in the mouth, but we can see them on the x-ray. In cases like that, a lot of times they will not be charted. You'll just have to look at the x-ray for them. Okay? So you will need to be able to look at an x-ray and find cavities in order to be successful on this part. Make sense, guys? Good. So once again, this is your clinical assessment, your adult clinical assessment. In other words, looking in the mouth. All right. So obviously we see he's missing multiple teeth, like I said. He has a cavity that we can see, just blatant, obvious cavity. No furcal involvement. He does have periodontal disease, right? And we can tell that by his probing depths. You guys see the probing that's written on here? Right? So we know when we probe from perio, if we have 1s, 2s, and 3s, those are healthy. When we start getting to 4s, that shows us that we have some gingivitis. When we get to 5s, that means we have gingivitis typically and bone loss. We are assuming that we have periodontal disease. In other words, we have some inflammation, right, which leads to gingivitis. But we don't know if it's periodontitis yet. We don't know if we've lost bone. Everybody understand that? Because we haven't looked at the radiograph yet. All right. The other thing that we can draw from this clinical exam is that we say that his oral hygiene status is fair. Okay. In other words, based on our assessment, regardless of his lack of teeth, he walks in and he looks fairly clean. All right. I would take issue with this because I see deep pockets, but I probably wouldn't have charted it like that. But that's what they charted. They said oral hygiene status is fair, so you got to go with it. The other findings, which is going to be under the supplemental oral examination findings, is that we have diffuse irregular white patches on the lower labia mucosa. What do you guys think that is? Diffuse irregular white patches on lower labial mucosa. Based on the two pages that we've looked at so far, the first page and this page, we know that he has a history that might contribute to that. Yeah, has to do with the chewing tobacco. Most likely. Lower labial mucosa, a lot of times with that irregular white patches, that's going to be caused by what they call nicotine stomatitis. Okay? So when they're using chewing tobacco, they're stuffing it into their bottom lip, and it causes nicotine stomatitis, which initially may be read. It did say he chewed. Let's see. He smokes 1 pack of cigarettes per day and uses chewing tobacco. Oh yeah. All right, we got everything that we can. We got everything that we can from those 2 slides. All right, now let's look at these x-rays. Now, guys, I hate to say it, these x-rays are probably as good as it's gonna get. Okay. Unfortunately, they're about as good as this on the boards. All right. Sometimes better, sometimes not. Okay. But we'll do what we can, right? So there's an arrow that's pointed here somewhere. Okay. If you look back over the radiology section, I give you guys some study guides to look at x-rays. You guys should be good at this by now. All right. It's kind of hard to see this, but we do see that he's missing multiple teeth, probably the same teeth that they noted. He has some impacted third molars. It looks like the sinuses have an extra lining or thickness to them, so we're concerned about that. All right. Looks like he had multiple recent extractions because we can still see the extraction site. All right. That's pretty much what I'm getting from here. And then from these beautifully taken full mouth x-rays, we can see that, in fact, he does have periodontal disease because we do have attachment loss, right? We have CAL. That was nicotine stomatitis. I meant to drop that in earlier. All right, so when we're looking at the necks of the teeth, remember when we're looking at bone loss, we're trying to figure out how far away this bone is from the CEJ. And we see that there is a difference here. We don't know what it is, but we know that there is a difference, which means that there is bone loss, which means this patient does have periodontal disease, if you couldn't already tell that from looking at his teeth, during the clinical exam. Now, let's move on to the clinical exam. So here on the clinical exam, once again, loss of teeth, loss of ridge height, okay, loss of bone, a lot of attrition on his teeth, a lot of non-carious cervical lesions. And here is the nicotine stomatitis on his lip. That's from packing in that tobacco. All right. So our questions. The plaques, so starting with this first question here. All right, the plaques on this patient's lower labial mucosa. Oh, dang it, I already gave you the answer. All right, the plaques located on the patient's labial mucosa most likely represent which of the following? No, you guys don't. You guys don't have this page. That's why I asked if you could see the questions. I just wanted you to see the things. Oh, wait a minute. I just saw another answer on here, so I'm gonna have to change my answer. I hope you guys didn't pick the one. I hope you guys didn't pick B. If you couldn't pick B, what would be your other option? Good. All right. So I would actually, looking at these answers, I would actually pick E. All right. Because with nicotinic stomatitis, initially you'll get a red lesion, and then it will turn into a white lesion, which is the smokeless tobacco hyperkeratosis, sometimes also called nicotinic keratosis. Okay. So keratosis meaning what? Keratosis is a thickening, right? It's a thickening of the tissue due to keratin being displaced. Good. Nice. Zoom in a little more. Let me see if I can. That better? All right. All right. So, giving these answers, I would pick E rather than A. I'm sorry, rather than B. Now, A is not the answer because leukoplakia is could be an answer. Leukopenia could be a differential diagnosis, but based on the history that they gave us, the fact that he uses smoke and smokeless tobacco leads us to the most probable diagnosis of smokeless tobacco keratosis. Good. All right, next question. Which of the following represents the structures indicated by the arrows in the radiograph? So go look at that radiograph one more time, the pan, and look at that arrow. So let's go to the radiograph and look at the arrow together. All right, so we're looking at this arrow. Okay. So drawing a line here to here. So it's hard to tell if they're pointing to the floor of the sinus or the zygomatic process of the arch. I'm sorry, of the right side. I'm going to say that that's the zygomatic process that they're pointing to. Does look like it's a little, maybe a distorted image. Here we go. Yeah, so we're going to say D is the answer. So let's figure out why E is not the answer. E says the posterior border of the maxillary sinus. What view would you need to be able to see the posterior border? A ceph, right? You need a ceph pointing from one side to the other, from the left to right. In order to be able to see the anterior and posterior border of the sinus, you need a lateral image, right? You have an image that's pointing from the side of your head. So if we were going to say that was if that arrow was indeed pointing at a point on the sinus, if anything, it would be the lateral border of the sinus, right? Not the posterior border. So that's why posterior is wrong. It's definitely not the pterygoid plate of the sphenoid because that's too high. Yeah, it looks like the zygomatic arch is in kind of like an interesting position, which is why I said that the X-ray looks slightly distorted in that area. But based on these options that we have, we know it can't be those. An innominate line is not an option. That's just weird. All right. So this is where the case questions get interesting. All right. So now they're not asking you about what you can see, they're asking you about what you know about treatment. Okay. Prior to undergoing scaling and root planing, how should we treat this patient? What should we give this patient before we go and clean their teeth? Three years ago. But does it matter, right? You guys remember the ASA guidelines for SBE? Guidelines. So here's the guideline for joint replacement. According to the ADA chairside guide for patients with a history, you guys can see my screen, right? It's from the ADA website. So these are the rules. All right, that's a little easy to read. All right, where were we at? Joint replacement. Okay, according to the ADA guide, chairside guide for patients with a history of complications associated with their joint replacement surgery who are undergoing dental procedures that include gingival manipulation or mucosal incision, prophylactic antibiotics should only be considered after consultation with the patient and the orthopedic surgeon. In cases where antibiotics are deemed necessary, it is appropriate that the orthopedic surgeon recommend the appropriate antibiotic regimen. Okay, when reasonable, you can write the prescription, but you should be referring them to whoever their specialist is to get it. Okay, other than complications coming from having the joint replacement, all right, patients with joints do not need, people who've had joint surgery, regardless of when they have, don't need to have antibiotic prophylaxis. Okay. So once again, this is on the ADA website. You guys can look this up. And when you click through here, you can go through in more detail what's being said. But here, once again, in general, for patients with prosthetic joint implants, prophylactic antibiotics are not recommended prior to dental procedures to prevent prosthetic joint infection. Okay, so there is no time line, even though they said 3 years ago here. Based on the old protocol, this patient would have gotten 2 grams of amoxicillin, right? But based on this new protocol, the patient gets what? Good. Patient gets nothing, right? No need, because we have no history of complications. And if we did have history of complications with the joint replacement, we would refer him or defer to his physician. Make sense? Cool. All right. Which of the following risk factors is most likely to contribute to future attachment loss for this patient? Well, the probing depths that are greater than 3, these are managed. Remember when we talked about perio? Probing, when we have pocket depths that are larger than 3s, this is managed by removing the etiology, right? So removing those pocket depths, removing the source that is causing those pocket depths, which is the plaque and calculus, right? So as long as we clean that calculus off and the patient is able to brush, whether or not they smoke, the pocket depth should be reduced. Now, one thing that we know about smokers is they tend to have poor circulation and short pockets, right? Pocket depths they don't tend to get a lot of gingivitis per se, okay? Really, it's more the fact that we've lost blood supply, okay? When we lose that blood supply, we don't heal very well, okay? And that tends to cause the greater attachment loss. Now, one thing that they put in here to try to throw you off a bit is this insulin administration, okay? Insulin administration itself does not contribute to the risk for attachment loss. Diabetes, however, does. Make sense? So the fact that you're treating the diabetes with insulin doesn't institute a greater attachment loss, but the fact that you actually have diabetes does contribute to it. Right. So the answer here is E. The right answer is E, smoking. Smoking is the one thing on here that will contribute to the future attachment loss of this patient based on the history. All right, not based on what you know, but based on the history of the patient, what they actually do. This is what they do that will contribute. All right, we'll do this one last question for today, and then we'll pick up again on Monday. All right, there is a vertical defect on the mesial of tooth number 2. Okay, there is a crater defect between tooth number 2 and tooth number 3. We have a vertical defect on the mesial of tooth number 2. Is there a crater defect between 2 and 3? We have mesial of tooth number 2, and then in between tooth and 3. So, or 2 and 3. Let's look at that. So on the distal of tooth number 2, we have a pocket. Okay, I can see it on the perio charting. In between 2 and 3, looks pretty normal on the perio charting. Let's look on the X-ray. So on the X-ray, I don't know if I see that. I don't see vertical bone loss distal to number 2. All right, remember there's a difference between horizontal bone loss and vertical bone loss. Vertical bone loss means you have something that looks like it's coming down towards the apex, like an angular bone loss, right? Like somebody took a sword and chopped into the bone. Okay, so I don't see a vertical defect distal of tooth number 2. All right, I just see a defect there. It's even more evident when you look at this top bite wing. Okay. All right, and a crater defect between 2 and 3, and I'm looking once again at this top bite wing here. All right, looks somewhat like a crater. All right, let's revisit those probing depths real quick. We have 4s and 5s on the buccal and the lingual. All right. And then let's see what our answer options are again. All right. So we already know there's no vertical defect. So both statements cannot be true. So A is not an answer. And C is not an answer because we already know A is not true. The first statement is false. So our only options right now are B and D. Okay. So the real question is there a crater defect or is there not a crater defect? Well, crater defect looks just like what I saw on that x-ray. Okay. So on this x-ray here, you look closely at it. Here we go. So if we look closely at this, we see that we have horizontal bone loss distal to tooth number 2, and we literally do have a crater of bone loss in between 2 and 3. So the right answer is D. And a crater defect just means that there is a divot. So the bone goes up on the along the root surfaces of the teeth, but when you get towards the papilla, you have a loss of bony structure. Can I point to vertical bone loss? I don't see any on this x-ray. Let me look around. Give me a second. There's no significant evidence of vertical bone loss. Oh, tell you what it is. Yeah, so if, so for bone loss, when you're looking at bone loss, first of all, you want to judge it from the bite wing. Sometimes it'll be a vertical bite wing. Sometimes it'll be a horizontal bite wing. This happens to be a horizontal bite wing. Give me a second, I'm going to show you. So when I'm looking at this bone loss here, I see that the bone loss along this side is fairly straight. Okay, this is for the most part, horizontal bone loss. Okay, I'm not sure where the bone is here. You can't really see it. Maybe it's right here. Okay. All right. And then the crater bone loss is right here. We have, it comes in, it goes out like that. That's the crater. If we were going to have vertical bone loss, it's almost vertical bone loss here. But basically what you have is, if you have vertical bone loss, you have bone starting high on one tooth and ending low on another. So if the bone does this, that would be vertical bone loss, if it looked like this. Make sense? Cool. All right, guys, it's been fun. Once again, we're done with all of our subjects, so now we're doing cases, and I love them. So we will see you again on Monday at 8:30.